This is Dr. Barry White, and I'd like to welcome all to this open meeting for 6 draft policies that have been now put for publication and for consideration on the Medicare coverage database. There's some housekeeping that we need to discuss. Again, all callers will be placed on mute upon login. You probably already found that out. When it's time to speak, you just click the raise hand, as it says here, and when the facilitator calls on you to speak, make sure that your telephone or headset is not on mute. Also, be sure that your computer speaker are on mute when you're speaking so there is no echo. This meeting is being recorded and transcribed as directed by CMS. To aid in the transcription, please introduce yourself before you speak, and also if you would list any potential conflict of interest that you feel should be provided. The policy comments at WPSIC.com is a very important email address to remember, because all comments need to be addressed in writing to this mailbox to be considered. Comments that are not submitted over to the mailbox will not be considered. Next slide, please. We'll go ahead and get started with the proposed LCDs. The first one in order on your agenda is allogeneic hematopoietic cell transplantation for primary and refractory or relapsed Hodgkin's and non-Hodgkin's lymphoma with B-cell or T-cell origin. Quite a mouthful, but what we've been requested by particularly ASH and ASCO to cover this, even though it has not been a problem with coverage, the hospitals certainly want to have some verification of coverage. This policy was an adoption of a policy from Palmetto in response to these requests. The policy addresses additional local coverage for allogeneic stem cell transplantation, as mentioned above, meeting the statutory and CMS criteria for reasonable and medically necessary coverage and reimbursement. The overall review of the evidence is consistently supportive of potential benefit. Patients who suffer from such diseases may have no other available therapeutic options for curative intent. Effectiveness in such patients has been identified and counts for its inclusion in many national oncologic hematologic clinical practice guidelines that are evidence-graded. The development of reduced intensity conditioning, the adoption of maximum age increases for transplant program patients, and improved screening for and treatment of comorbid conditions in an older population supports the expanded therapeutic scope. Age is not to be considered as a contraindication for this procedure. We're fortunate to have Dr. Joseph McCurrick, a professor of medicine at the University of Kansas Center Cancer, to now give us a presentation on this topic. Dr. McCurrick.
Dr. McGurk, I have placed you in the panelists, and you can unmute at any time. And we will have Mel set up your screen share. Okay, Dr. McGurk, you should be able to click the unmute icon on your screen. There we go.
Okay, are you able to hear me?
Yes, I can hear you.
Yes, we are.
Thank you. Thank you for the opportunity to present. This is Dr. Joseph P. McGurk. I am the Division Director of Heme Malignancy and Cell Therapy at University of Kansas, as mentioned, and I have no conflicts of interest pertinent to our presentation today. Allogeneic stem cell transplants represent a curative treatment approach for many patients with hematologic malignancies. Patients aged greater than 65 years of age or greater with certain hematological malignancies such as myelodysplastic syndrome, myeloma, myelofibrosis, or non-Hodgkin's lymphoma with Medicare as primary insurance in the United States historically did not have coverage for allogeneic transplant, leading to disparities in access between those with private versus Medicare insurance. Further, allogeneic transplant indications more recently have been approved for myeloma, myelodysplastic syndrome, myelofibrosis, sickle cell disease, having acquired CMS coverage. Coverage for allogeneic stem cell transplant, in contrast, for non-Hodgkin's lymphoma in the United States is limited to only those states that are in the National Government Services jurisdiction. Most patients aged 65 years of age or greater in the United States receive their primary insurance coverage through Medicare, and most private insurance providers follow CMS guidelines. This means that the vast majority of patients 65 years of age and greater with non-Hodgkin's lymphoma lack access to this potentially curative treatment modality. As you can see in this slide, of the SEER national data from 2015 to 2019, representing all races and both sexes, the median age at diagnosis of non-Hodgkin's lymphoma is 67. And as you can see the distribution here, 58% of patients are equal to or greater than 65 years of age. The development of reduced intensity conditioning regimens and non-myeloablative regimens has resulted in increased utilization in older patients. Next slide, please. These data published by Shah et al. In Blood Advances in 2018 reported on 1,629 non-Hodgkin's lymphoma patients from 2008 to 2015 from the Center for International Blood Marrow Transplant Registry. In this report, 446 patients were 65 years of age or greater, and 1,183 patients were 55 to 64 years of age. And what you're seeing here in the left-hand side panel on the upper part is non-relapse mortality, which is slightly greater, but statistically so in the older population of patients. However, in subsequent multivariate analysis, the statistical significance was lost. In the lower panel, in the B panel on the left-hand side, is the relapse progression of disease, and you can see those curves are superimposable, and they are not different. On the right-hand side, very importantly, in A is progression-free survival, in B is overall survival, and there is no statistical difference between these two age groups. Next slide, please. The same author, Shaw and colleagues, reported in Blood Cancer Journal 1 year later a CIBMTR registry analysis of 727 patients greater than 65 years of age undergoing allogeneic transplant, and divided these patients by time period, 2000 to 2005, 2006 to 2010, 2011 to 2015. And what you're seeing here is on the left-hand side, progression-free survival went from 17% in the earlier period to 31 and 30% in the second and third periods, and overall survival went from 21% in the initial period to 42 to 44% in the second and third periods. What you don't see here, but is reported in this data set, is 30% mortality reduction from 2000 to 2005 to the 2011 to 2015 time period. And that's quite remarkable, given that 50% of patients had significant comorbidities and a comorbidity index of 3 or greater. Next slide, please. Further, these are CIBMTR data demonstrating that the age of patients has steadily increased over many years, year over year. So if you look at the right-hand side, the number and percentage of patients 65 years of age and greater has significantly increased, and this has been made possible through reduced intensity, non-myeloablative conditioning regimens, and better supportive care post-transplant and patient selection based on fitness. Next slide, please. In addition, the types of stem cell sources have changed over time, so that now the majority of stem cell sources for patients 65 years of age and greater are represented by unrelated donors, or increasingly haploidentical family donors or mismatch unrelated donors. Next slide, please. The national efforts that we're talking about today has long been supported by the American Society of Hematology and American Society of Transplant and Cell Therapy. An LCD submission to each MAC is planned by these societies. As mentioned, the Palmetto region is finalized and active. Meridian region, comment period is closed. The WPS, our own region, comment period is open, and the CGS region, comment period is open. This presentation has been organized by colleagues at University of Kansas and supported by our colleagues at Washington University, University of Iowa, and University of Nebraska. There's a great regional unmet need, as I described earlier, and sending patients outside of the region for allogeneic stem cell transplant presents real challenges for our patients. Next slide, please. Those challenges are represented here by financial, travel, lodging, food, increased time away from work, all pose significant financial hardships on patients to travel to a transplant center in a MAC jurisdiction with an LCD in place for allotransplant. Social support, critically important for our patients' well-being, is problematic in that the patient and caregiver must reside within 30 minutes of a transplant center for 100 days after transplant. That's a national standard. Caregivers required 24/7 for that, 100 days post-transplant. And continuity of care is breached here. The patient must reestablish care with a new medical team, causing breaking continuity and a delay potentially in transplant process. Further, there's lack of familiarity with the new team and area, causing significant psychosocial stress potentially. And finally, frequent long-term follow-up, which is required of these patients lifelong. Patients must return at frequent time-specific intervals to complete post-transplant evaluation for a lifetime and survivorship, compounding all of the above hardships. Patients are less likely to comply with required follow-up, increasing risk of post-transplant complications and leading to missed early relapse detection. And most importantly, loss of life, because many patients simply can't afford to travel long distances to a center and will succumb to their disease. So as mentioned earlier, age by itself is an insufficient and often inaccurate determinant of medical fitness for any specific treatment, including allogeneic stem cell transplant for lymphoma. Coverage for Medicare patients to receive allogeneic transplant for non-Hodgkin's lymphoma is endorsed by the American Society of Hematology, the American Society of Transplant and Cell Therapy, and the National Marrow Donor Program, or Be the Match. Our former American Society of Transplant and Cell Therapy, Dr. John Topercio, Professor of Medicine at Washington University in St. Louis, will speak next. And then we have a patient who is facing this very challenge, who I believe plans to speak as well. Thank you for your time and attention.
Thank you very much. If any commenters would like to raise their hand and be recognized, please, at this time.
We have a John Dispersio. I've just sent a request for him to unmute.
Thank you very much. And I don't have much to add to Dr. McGurk's excellent review. I would just say that the data that he reviewed was registry data encompassing many centers around the country. We're one of the largest centers in the Midwest in our Medicare region. And our data that I sent to Dr. McGurk, it's not in the slide presentation, is almost identical to what he showed. And I just want to emphasize that most of our patients, of the 166 patients that we've transplanted since 2010 for non-Hodgkin's lymphoma, have been over the age of 60 and 70% over the age of 65. And median, the overall cumulative survival over 10 years, we have 10-year survival data, is 50%. And that, in transplant terms, represents a substantial enhancement not only for the life of the patient, but also for the quality of life of all the family that are so close to these patients and have to care for them. So I echo what Dr. McGurk has said about the relative issues of age. And more important than age are comorbidities. And if the comorbidities are acceptable, age does not seem to be a significant risk factor for outcomes after allogeneic stem cell transplant, not only for non-Hodgkin's lymphoma, but for other diseases such as MDS and AML. So I echo his support for this being approved for Medicare patients in our region.
Thank you so much. Any other comments?
I currently see no hand raises at the moment. If you are on a phone, you can press *3, and that will bring up the hand raise icon for me. It appears there are no further comments at this time, Dr. Weitz.
Thank you very much. The second item that we have is one of three molecular diagnostic testing or assays, and this is for cutaneous melanoma. It is DL39479. It is to assist dermatopathologists to arrive at the correct diagnosis of melanoma versus non-melanoma when examining skin biopsies. It will provide limited coverage for DNA RNA assays that aid in the diagnosis of, or exclusion of melanoma from a biopsy when all of the 7 clinical conditions are met as listed in the policy. We'll not go over those just for brevity. I'm sure most of the dermatopathologists and the physicians treating cutaneous melanoma certainly, hopefully, you have reviewed the policy. The studies demonstrate that Medicare beneficiaries with diagnostic challenging slide results or history will have improved outcomes as defined by an increase in accurate diagnosis, appropriate clinical management, interventions, and a reduction in burdensome and unnecessary treatments. Are there any comments to this draft policy?
I do see a hand raise from a Lisa Mack. I am requesting unmute at this time.
Please proceed.
Hello, Dr. McGurk, good afternoon. My name is Lisa Mack, and I'm a Medicare beneficiary from Kansas City, Missouri. First and foremost, I want to thank you and the KU Med team for giving me the opportunity to tell my story. I've been under the care of Dr. McGurk and his amazing team since 2021. I was originally diagnosed with stage 4 mantle cell lymphoma in 2015 at 54 years old. I've had multiple lines of treatment, including R-CHOP, an auto transplant, Imbruvica, CAR-T, and now Revlimid and rituximab. All doctors agree this 5th line of treatment must be an allogeneic transplant, and it's my only curative option. Unfortunately, I cannot proceed with this life-saving treatment in Kansas City due to the lack of clear coverage for the procedure in my Medicare area. So I'm traveling to Memorial Sloan Kettering in New York City to undergo my transplant. There is currently an LCD in place for that Medicare region, specifically allowing coverage. Have I lost time because of this change? Absolutely. Time is my enemy now. Just so you know, I don't wallow in my fight against this insidious disease. I walk 3 miles a day, I work out, and I have at least 30 medals of half marathons, 10Ks, and 5Ks while I executed either in remission or out of remission. With these factors in mind, I want to strongly advocate for the prompt approval of this LCD for myself and all the Medicare beneficiaries in the WPS region. When, not if, Medicare rules and regulations allow, I ask you to please expedite approval and the effective date of the LCD in any way possible. As a sidebar, I told Dr. McGurk that the Palmetto jurisdiction was recently approved. His question was, how long did the approval take? My answer was 2 to 3 months. His answer was, Lisa, you don't have that time. If this were in place today, I could safely transplant in Kansas City, eliminating many of the adverse factors mentioned. I can attest that traveling to New York for this transplant is a hardship, as Dr. McGurk mentioned. The cost of travel, lodging, food, and other incidental expenses will likely total roughly $30,000. This does not even take into account the financial cost my caregivers will face from time from work, family, and their daily life. I don't have 24/7 caregivers in New York City. I do have significant and a close network of people here in KC that would be with me for 100 days after transplant. I literally live 5 minutes from KU Med. The social and emotional stressors this places on my life can't be quantified as easily as the monetary stressors. Please imagine for a moment leaving your friends and family for this time period to undergo a transplant several states away from your home. The psychosocial impact is immense. Since I reestablished care with my new medical team and my disease requires the allogeneic transplant, Dr. McGurk and his team expedited my referral to New York to minimize time lost during donor search and actual transplant. Truly, my objective is not about me, but for the hundreds, maybe thousands of Medicare patients in our jurisdiction and perhaps across the country who are struggling with this disease. If I can help this team secure your approval, it will be one of the greatest accomplishments of my life. Again, I ask you to please expedite your decision and the effective date of the LCD as quickly as possible. Thank you for your time.
Thank you so much for your comments. I would note that our limitations as far as notice period, comment period are fixed by law. I would also encourage you to speak back to Kansas City concerning the fact that this is a coverage policy that will be in effect. And as far as I am aware, individual consideration is given to each and every patient on an individual basis by WPS on patients who have undergone this procedure prior to the finalization of this proposed policy. So we just asked them maybe they could review that because this may not really be that big of an issue for you if individual consideration is granted. Again, each patient and individual consideration is based on their own history, their own review, and again, we do not have a non-coverage policy. We just don't have a policy, period. So the fact that this policy of coverage is not out yet does not mean we have a policy that says you can't get it. Just remember that. Any other comments on the first item, the allogeneic hematopoietic cell transplant, and again on the molecular assay for cutaneous melanoma comments? Any comments on that for us, please?
All right, I see no hand raise icons at this time.
Okay, thank you very much. We will next go to the third item on the agenda, and that is for biomarker testing for guide targeted therapy for selection in patient rheumatoid arthritis. Currently, molecular biomarker tests for targeted therapy for rheumatoid arthritis are non-covered by this contractor and all contractors, at least all MolDX contractors. This again is a MolDX policy. that was derived from the Palmetto Moldex contractor. We're partners with them, and therefore am able to make some contributions to this decision, or we can choose not to take the policy. An evidentiary CAC was held by the subject matter expert, was held across, these experts were diffused from throughout the United States, not just in the Moldex jurisdiction. The panelists were not aware of any such test that had been rigorously validated for routine clinical use at the time of the Evidentiary Care Advisory Committee was assimilated. Also, any international, national, societal guidelines have not been endorsed for predictive, that is a response to therapy biomarker testing to date. And members of this evidentiary CAC committee, while agreeing in the value of testing, do not think that such a test, in their opinion, had been demonstrated to warrant routine clinical use. Therefore, the clinical validity and utility it was not felt to have been established for the molecular diagnostic test for targeted therapy for rheumatoid arthritis. The contractor will continue to monitor the evidence and may modify coverage based on new information and the pertinent literature and societal recommendations. Now, we have Dr. Jennifer Dines, Vice President of Regulatory and Medical Affairs for Cipher Medicine, who has a presentation for us. Would certainly appreciate if you would state it prior to the presentation any conflict of interest that you may have. Dr. Dines.
Thank you very much. And yes, I have one conflict of interest as I am a full-time employee at Cipher Medicine. We at Cipher Medicine are appreciative of the opportunity to present and look forward to working with WPS to further support our coverage application and thereby provide this vital test to Medicare beneficiaries. Very briefly, and on the next slide, I wanted to introduce myself as it relates both to precision diagnostics and clinical coverage. As a clinical geneticist, I have focused my career on translating novel technology to the clinic to improve patient outcomes. With my keen interest in precision medicine at the University of Washington, I participated in the evolution of advanced sequencing technologies integration into medical practice and saw an enormous impact on patient care as it has transformed how we better treat and diagnose patients in the field of oncology. At Adaptive Biotechnologies, I expanded from oncology to the use of autoimmune and infectious diseases and helped the company receive FDA's emergency use authorization for a new class of diagnostics with a machine learning classifier-based blood test to combat the COVID pandemic. I'm now leading similar efforts here at Cipher Medicine. Towards that end, and on the next slide, I will be providing a brief introduction and background to our company and Prism RA, which has continued to gain adoption by the rheumatology community in parallel with the progression of studies that demonstrate its validity and utility in the clinic, and will conclude with the urgent need for this test. In the next slide, our company, Cipher Medicine, is focused on providing physicians with the right tools and solutions to deliver precision-based care to their patients. Doing so helps achieve the critical aims of improved outcomes, lower costs, and more efficient healthcare delivery. Specifically, in the next slide, Prism RA, the test we are discussing today, is already experiencing large-scale adoption across the country. Throughout the United States, physicians and their practices as a whole have been ordering our tests given its utility and necessity in the care of their patients, and is used by over 600 providers across 400 practices. Over 45% of our commercial tests come from patients covered by Medicare, and as such, our goal is to work collaboratively to improve access and coverage as we are doing today. Next slide. This summarizes our clinical validity supporting Prism RA's integration in the clinic. Prism RA has been clinically validated in both retrospective and prospective studies in over 800 patient samples and demonstrated consistent performance across multiple cohorts, with studies reporting close to 90% positive predictive value, solidifying the value proposition of this innovative test. Most recently, in the AIM study cohort at the far right of the slide, we evaluated the performance characteristics of Prism RA in 369 patients. The resulting performance included a PPV of 88%, thereby demonstrating the continued performance in a cohort nearly 3 times larger than prior studies, summarized on this slide. As 90% of patients with RA are treated with TNFi therapies as first-line biologic targeted therapy, PRISM-RA can accurately redirect patients with a molecular signature of TNFi non-response to an alternative therapy, increasing their likelihood of achieving targeted clinical outcomes, which I will go into more details after first clarifying a misinterpretation of our clinical utility data on the next slide. Here, we believe this to be a misinterpretation of a key result related to the utility of the test. As was noted in the draft non-coverage decision and detailed at the bottom of the slide, the conclusion reached was surprising to us at Cipher because an improvement over baseline and standard of care is exactly what we measured and achieved as a primary endpoint. As seen here on the left of the slide in Table 1 and highlighted, the absolute CDI average among the predicted non-responders for those receiving TNFIs and those receiving alternative mode of action were both in the 30s. After 6 months, and shown in the second table on the right, of those predicted TNFi non-responders, only 10% of the group receiving a TNFi achieved an ACR 50, while those aligned with the test results and on an alternative mode of action had more than 3 times, with 34.8% of patients achieving ACR 50. I will now review the clinical utility data in more detail on slide 8. As I discussed previously, our test has been clinically validated in over 800 patient samples, now depicted on this slide, prospectively evaluated for provider treatment selection and clinical outcomes in over 900 patient samples. It is important to note on this slide are both the end values of our studies as well as the primary endpoints achieved. Additionally, and highlighted in the table at the bottom of this slide, we assess the patient numbers and demographics further to determine the representative value to Medicare beneficiaries. Across the interim analyses, 22 to 36% of patients were 65 years of age or older, with females representing 80 to 85% of patients, and 25 to 32% identifying as non-white and/or Hispanic or Latina in this age group. I will now go over the study primary endpoints in greater detail on the next slide. From our peer-reviewed paper that brought our N value to 274 patient samples, that was published in June of this year, one key point represented below the letter B on the figure on the left. We see those with a molecular signature of non-response treated with an alternative mode of action therapy had a 1.8-fold greater improvement in CDI scores than those treated with a TNFi. In the next slide, we have submitted for publication an additional clinical utility paper that is pending publication. Here, we not only increased the N value of patients tested and outcomes measured to 489 patients, but also show that treatment selection guided by our test results in 1.5 to 2.9 greater improvement in outcomes after 6 months of biological therapy initiation compared to standard of care, external EMR-derived control group, where PRISM-RA was not used to predict therapeutic non-response to TNFi therapy. Next slide. And in response to MolDX draft LCD, we explore how robustly our test can predict TNFi non-response compared to clinical and serologic features in combination or alone. At Cipher Medicine, as well as key opinion leaders, including the members of the CAC and advocacy groups, we were surprised to hear that the contractor believes that tools and metrics are already available to practicing physicians and that the utilization of these metrics and values would provide predictive power comparable to PRISM-RA. Here I'm sharing from 2 analyses comparing clinical, serologic, and molecular features individually and in combination. We see that PRISM-RA, or MSRC shaded in gray, is better able to predict TNFi non-response more robustly across these 2 cohorts than any combination of clinical or serologic features alone. In the next slide, we summarize physician and advocacy group sentiments that continue to provide support of our test, reaffirm the dire need to incorporate PRISM-RA into their medical practice. Their support reaffirms the dire need, and this includes the devastating effects that occur as patients are trialed on different therapies until they find the right treatment to control their disease. Importantly, we know that patients who do not respond to their initial therapy are less likely to respond to subsequent therapies. Therefore, the utilization of PRISM-RA will help doctors make a more informed therapy choice and will improve patient outcomes as demonstrated in the body of evidence we reviewed today. Importantly, Medicare does not require TNFIs as first choice and second-line therapy, and Prismari's use in the clinic can be seamlessly integrated with decision impact with therapy decisions based on an individual's patient's unique biology. And I'll conclude with the final slide, which highlights and shifts focus solely on the patient and their journey. Here we see on the left-hand side and in gray, the patient's journey is long and arduous. Inadequate control of RA results in chronic inflammation, which can lead to joint damage, permanent disability, and poor health outcomes, including shortened life expectancy. Prior to Prism RA, management of patients with RA included a trial and error approach. Since this approach often fails to efficiently identify the most effective therapy, RA patients suffer prolonged, poorly controlled disease, irreversible joint damage, and an increased risk of cardiovascular disease, cancer, and death. As a physician myself, I fully understand the value of precision medicine tests and the need to provide coverage for them so that they can be made available to patients. With Prism RA and illustrated on the right-hand side of the slide, patients can avoid treatment they are unlikely to respond to and start the right therapy sooner, leading to improved outcomes. We respectfully request that WPS support Prism RA's LCD for this innovative test. As such, I will now conclude our presentation. Thank you.
Thank you very much. And any of the new data that you have out that would like for us to consider, please include that into the WPS policy comment mailbox if you would. And any and all comments, we need any documentation that you would like to, please be sure it is in the mailbox to us. I would appreciate it.
Thank you, will do.
Okay, thank you. Any other commenters on this MolDX policy?
Once again, please press the raise hand icon or *3 on your phone if you would like to make a comment. There are no comments at this time.
Thank you very much. The next one listed is sacroiliac joint injections and procedures. This is a 37-page redo of an LCD. And please be known, I am not going to go over all 37 pages. Just those who are doing the procedures, there are several limitations, a lot of different items. There are 6 items that are listed that must be present to consider it reasonable and medically necessary. The diagnostic joint injection have 5 criteria listed in the policy. The therapeutic has 4 criteria that all must be met. There are limitations on the number of procedures or sessions that can be done. It is all based on a rolling 12-month average. Also, there's a section on radiofrequency ablation. It is considered investigation and therefore is not reasonable and necessary by this policy. The scales that are to be used to measure pain and disability must be documented in the medical record. Again, that is pre-procedure as well as post-procedure, and that needs to be sure that's included to us because we can't guess on it when we ask for information. That must be in both pre and post. The requirements, there are 9 criteria to meet the coverage requirements that are in there, and that has to be from the technical aspect to the medical reasonable and necessary. There are 11 listed limitations in the policy, and this 37-page document, is filled with specific criteria and limitations, and just would encourage anyone who is planning on doing the procedure to be sure to look at all of these items because they're very important. And this was a multi-jurisdictional policy. It is had a lot of input, and I think that's the reason for all of the various criteria to try to nail this down as much as we can to be sure that the patients get the procedure that they need by the right individuals, the right amount of time, and that, again, you have comments or anything on this policy. Not only are we opening comments to you at this time, but if you're listening and have comments that you need to get in, they need to be in by the 12th of November, but we need everything in writing. Rich, if there are any see if there are any, if you would, any commenters on this policy now.
Once again, press the raise hand icon or *3 on your cell phone. And I see no indications of anyone wanting to make a comment at this time.
Okay. Thank you very much. The next to the last item is prognostic and predictive molecular classifier for bladder cancer. MolDX contractor has made a policy change, at least in their own way of doing things, and trying to get into more foundational policies, and which means that they'll have a test for bladder cancer, and under that will have the various tests that are to be considered instead of having a different policy or different LCD for each test. This is being added to the foundational policy for bladder cancer, and it is a coverage policy with a beneficiary for bladder cancer has certain criteria that are being met. And all of those criteria are very specific. They are listed in the policy. And if you are performing this test or ordering this test, be sure that you have read the criteria that needs to be met. The coverage criteria are very important. They're very sensible. And also that the test has been shown that you're requesting predicts response to therapy among accepted therapy options based on nationally recognized societal consensus guidelines such as NCCN, ASCO, AUA, and the Society of Urological Oncology. We'll now entertain any comments on this proposed draft L 38684.
All right, once again, the raise hand icon or *3 on your phone if you would like to make a comment. And there are no current comments on this LCD.
Okay, number 5 on the list, number 6 on the list, excuse me, I guess it is. Number 5 on the list is the predictive test for drug testing. And this is a test that came about because of Department of Justice and OIG findings of inconsistency among the MACs as far as their LCDs were concerned. There were different verbiage. There was more in some, less in others. Some contained one, some did not contain the other, and vice versa. It would go back and forth. So a work group was reconvened, and a multi-jurisdictional policy was derived based on a lot of hard work by members of this work group, trying to be sure that the necessary parts of each policy were continued and the superfluous items were removed. Also, new data was in, and we have had significant conversation with CMS, as well as the legal DOJ, the Department of Justice, General Office of General Counsel, and to make this a policy that seems to be, I think, one of the better ones that I've been associated with. It is, again, it is a revised collaborative process for consistency and clarity of coverage. It contains several definitions which were not present, both for the presumptive and definitive test, the limitations, reasonable necessary criteria, and one of the major items is that 14 classes of drugs, and this is a urine drug testing, so we're not talking about blood tests. It's 14 classes of drugs to be the maximum number of classes considered for definitive testing, based on several references that are listed in the policy. In this policy, we've maintained the 3 groups of patients that were defined in, I think, every one of the previous policies, including those who are on chronic opioid therapy, those who have been on substance abuse, and those in acute emergency room situation where consciousness or bizarre behavior has been noted as the 3rd criteria. The changes that have been made to this policy are consistent with other MACs and help resolve issues as noted with the OIG determination of potential overpayment for definitive testing. We're not restricting any testing that has been present previously, but we are grouping our classification into 14 classes of drugs, and which would include all of their metabolites and related drugs in one item. Will now entertain any comments on this policy, please.
It appears we have a question from Amy Turner.
Ms. Turner, please go ahead.
Okay, I've requested unmute for Ms. Turner.
You said this is a multi-jurisdictional policy?
Yes, it is.
Okay, and all of the MACs will be participating?
Yes, ma'am.
Okay, awesome. Thank you.
Quite welcome. That brings us to the end of our proposed LCDs, and this last LCD was, our draft policy is 34645, the drug testing. I would again ask that all verbal comments please be entered, as well as any documentation. We do not want to have just what a reference is. We need a full copy of that reference if you have it. I don't need summaries. I don't need abstracts. I don't need posters. I need peer-reviewed items to review. The last day, again, for submitting comments is 11/12/22. After that, there will be a response to these comments written in part of the, and registered in the Medicare coverage database under each one of these proposed tests. And they will then go with another notice comment for 45 days after our comments are out. So once the final is done. Overall, are there any other questions for me, or we mentioned that our, it looks like we have Dr. Denise Nachotsky on today, Dr. Robert Kettler, and I'm trying to see, we have a, Joelle, are you on at all? I don't see you on the, Evan, you see him helping with our innovation project and was scheduled to be on the call, but I see her on the list. I think everyone is familiar with Dr. Nachotsky and Dr. Kettler.
She is on the list. I apologize. I'm moving her up to panelist right now.
Okay.
Dr. Vlahakis, you should be able to unmute yourself now.
Yeah, I see you. Yes, if you'd give us a brief summary of your training and what you've been doing, that would certainly be helpful, I think, to all of us who are trying to get to know you better. Star 6.
Dr. Vlahakis, I see that you are not on mute at this point, so you may have an audio connection issue.
So just try star 6 and see if that'll get you connected. Okay, well, wait, maybe next time. But she is part of our new CMD staff, internal medicine, has done hospice, has significant exposure to governmental regulations, and will be a welcome. Did I hear you?
You do. I'm so sorry about that. I'm very technically challenged. So I thought I had it all set up. So I'm Dr. Joelle Vlahakis. I'm an internal pediatrician by training. Spent about the last decade in the hospice and palliative medicine world, most recently in the hospital setting, doing palliative medicine. I'm very excited to be here. Have practiced mostly in Florida and done all kinds of work, including work in rural health will hopefully serve me well, as I've been very fortunate to find myself working on an innovations project here at WPS. I'm really excited to try and move the needle on giving our patients what they need, especially those in high-risk groups. So thank you for having me.
Thank you very much. I think we still have a bad connection, but appreciate your being here and listening. Any other comments for the meeting before we adjourn? Rich, any other housekeeping we need to do?
We do have a request that you state or spell Dr. Vlahakis's last name and confirm that she's a new CMD.
Are you going to spell your name for me, or?
Yes, I apologize. It's Dr. Joelle Vlahakis, V-A-L-A-H-A-K-I-S. I apologize. V-L-A-H-A-K-I-S. Vlahakis. Joelle, J-O-E-L-L-E. She is the new CMD covering the MAC Innovative Challenges for Depression Screening and Chronic Care Management.
Anything else? Okay, we will call this meeting to be adjourned. Thank you very much for everybody's attention. Thank you.